So cholangiocarcinoma is an aggressive disease. Sadly, the therapies at the moment are limited to a first-line chemotherapy-based treatment. We have a clearer understanding of the genetic changes that can occur with cholangiocarcinoma, and one of those changes is the mutation of IDH1. IDH1, when it is mutated, it can cause a reduction of alpha-ketoglutarate to 2-hydroxyglutarate. That is an oncometabolite that can cause oncogenesis changes. The mutation of IDH1 can occur in about 20% of the patients with cholangiocarcinoma, and we don't see that it does favor a good outcome. As such, and based on a phase 1 clinical trial that included a cohort of about 73 patients with cholangiocarcinoma, we saw an improvement in the progression-free survival to 3.8 months and overall survival to 13.8 months, and this was enough justification to carry on with the ClarIDHy study that evaluated ivosidenib versus placebo in phase 3. So in the phase 3 clinical trial, the ClarIDHy, which was a global phase 3 randomized double-blinded study for patients with advanced cholangiocarcinoma and mutated isocitrate dehydrogenase 1 or IDH1. Patients were eligible, had to have a evident histologically of the cholangiocarcinoma. They had to have a mutation of the IDH1 confirmed, good performance status, at least 1 and maximum 2 prior lines of chemotherapy that should include gemcitabine or 5-fluorouracil. Patients were randomized after confirming the mutation to 2-to-1 randomization to ivosidenib at 5 mg daily that was done in continuous fashion versus placebo. Very importantly, the patient on the placebo arm, and especially because they have the mutation, to be given the opportunity to be still be evaluated with the drug or get the opportunity to be exposed to the drug, were allowed to cross over upper radiologic progression to start on the ivosidenib. The study primary endpoint was progression-free survival. There was a clear separation of the curves that was kind of like start being seen right at the time of the first CAT scan, which is about 1.5 months. Hazard ratio was 0.38 with a p-value less than 0.001. And in addition to that, the median progression-free survival was 2.4 months versus 1.8. More importantly, though, because of the separation of the curve happened at the start of the first CAT scan, we saw a continued separation with at least at 6 months progression-free survival, 32% of the patient on the ivosidenib arm were still progression-free and alive. And also a 12-month progression-free survival was 22% for the ivosidenib. While interestingly, for the placebo arm, both the 6 months progression-free survival and 12-month progression-free survival were not evaluable or estimable because there were no patients there. So the progression-free survival was appropriate justification for different reasons, among which, yes, we wanted to give the opportunity for everybody, and same time I give a lot of credit for the advocacy groups that really supported the exposure and the opportunity for patients to be at least given a chance to be evaluated while getting on the ivosidenib. The drug was rather well tolerated. The common side effects or adverse events that we have seen all across the grades were 3, pretty much nausea and diarrhea and fatigue. When it comes to grade 3 or above adverse events, the ones that were commonly seen were anemia, increased bilirubin, increased AST, and ascites. Interestingly, though, the numbers were acceptably low, and if anything, the drug was, and on personal experience, was rather well tolerated. Add to the progression-free survival that we discussed, the overall survival in view of the crossover, we were able to calculate it based on what we call a RPSFT method that will allow us to evaluate the overall survival for the placebo arm as if the patients never crossed over, and we ended up with a 10.8 month for the ivosidenib arm versus 6 months for the placebo arm, with a hazard of 0.47, p-value less than 0.001. Between the results of the progression-free survival as primary endpoint, as well as the overall survival, add to other positive points, among which the response rate, which had showed quite a bit of stable disease in view of the cytostatic nature of the drug, and of course the tolerability based on the adverse events profile. I think this will be hopefully practice-changing and will be an opportunity that will be available for patients with advanced cholangiocarcinoma and mutated IDH1.